Thank you, Dave, for that introduction. Thank you, Dr. Wakabayashi. My job is to try to share my thoughts on synchronous colorectal liver metastasis, as well as give you a little bit summary of what is in the literature. These are my disclosures, but should not affect the content of this lecture. Then we all know that colorectal cancer is one of the most common cancers, but I want you to concentrate that 80% of colorectal liver metastasis patients are unresectable at diagnosis. And the synchronicity, it's a sign of poor prognosis. This is according to a 2019 paper by Adam. Hepatic resection for metastatic cancer is not new. It's actually over 50 years old. This is a first publication back in 1967. But what really changed the concept was in 1984 when Asbun in Mayo Clinic did show that there was a significant improvement in terms of overall survival for those patients that were resected versus the ones that were not resected. And this is again on the same paper by Adam today in 2019. We have a much better survival on those patients after resection than on those patients that were not resected. Granted, this is a little bit biased because today this is not natural history. This is the fact that these patients, the 9% survival, were unresectable. Then in terms of definitions, even though this is straightforward, just to talk, synchronous metastases are the ones that are diagnosed at or before diagnosis of the primary tumor. Early metachronous within 12 months, and this is important in terms of the overall prognosis because an early recurrence is going to give you a much more aggressive biology of the disease. Late metachronous, more than 12 months. Then this is what's all about. In the past, it was almost like no doubt. You usually started with the colon and that was it. But then as chemotherapy became better, and we'll show you some slides, there was no doubt that chemotherapy played an important role. And when you do stage, do you do colon resection first? Do you do liver resection first? Or do you do a synchronous resection? What is the rationale, and this is relatively new, of liver resection first? Well, liver is usually the more difficult operation. Liver metastases are usually the cause of death, and it does require, in order to do liver first, the absence of a bowel obstruction, obviously. When you compare synchronous or colon first, in terms of the type of the resection, if you look at a forest plot, you see that the standardized mean, basically, of all of these studies in a meta-analysis shows that there's basically no difference. The standardized mean here on a diamond black shows that there's no difference between the ones synchronous and the ones that were staged by colon first. And this is interesting because in overall prognosis, you would think that the faster you go to do the liver, the better it's going to be, but this did not show it. Another meta-analysis that now says colon first or liver first. This was in Annals of Surgery. Interestingly enough, if you do the colon first or the liver first, did not change at all. Now, synchronous, colon or liver first. This was a meta-analysis of different approaches, and you can see on the paper by Bruquette, these are the means on the papers from Mayo Clinic and on the papers by Vanderpool. Then you can see that overall in all of these three papers, it varies all over the graph. But if you do a forest plot, again, really no difference between these studies when you put them together, even though individually there was a difference. Now, going back to surgery first or neoadjuvant chemotherapy first, this became much more clear in the recent years, and we know that chemotherapy does have an advantage, and we have longer survival with the standardized mean sample towards the left of the curve, in this case favoring chemotherapy first. If you do no chemotherapy versus chemotherapy, you have a better survival on the patients that have neoadjuvant therapy, that it is significant. What about the conclusions on terms of chemotherapy? It seems pretty clear that FOLFOX remains the regime with the best evidence of potential benefit for patients that are resectable, and therefore neoadjuvant therapy appears to be the best aspect. In terms of consensus guidelines, in the ESMO consensus guidelines, it does state that the majority of opinion is that the patients presenting with synchronous metastasis should be treated more aggressively with preoperative chemotherapy. Another consensus guidelines, this states that resectable liver metastasis, first you do chemotherapy if it is asymptomatic, and then you do 1 or 2 stage, but for symptomatic colorectal cancer that are obstruction or fear of perforation, then the colon should be done first. Obviously, for non-resectable liver metastasis, chemotherapy followed by liver first if resectable. Again, going back towards the thought of liver being the most difficult operation, and if you're not going to be able to clear the liver and you have the tumor under control in the colon, there's no need to do a colectomy as long as you're doing it in chemotherapy. The NCCN guidelines basically allows you to do almost anything you want to do, either first colon or liver first or synchronous, but the general agreement is that you should do chemotherapy first. And then the tree goes down depending on the location and amount of load of chemotherapy. The American Society of Colon and Rectal Surgeons on the clinical practice guidelines, again, says the same thing. The sequence of chemotherapy, resection of primary tumor, and the resection of metastasis should be individualized and determined by a multidisciplinary consensus. Meaning in the local institution, there should be a multidisciplinary team. And I think that's the most important thing that we have learned with all of this confusing data that some paper says one is better, the other one is better, is that we do need multi-specialty team and tailor to each patient. The colorectal liver metastasis in terms of multidisciplinary approach, again, summarizes that there's no consensus of the ideal management. They are targeted biological agents and local regional therapies that basically help you treat these patients and improve favorable results. And evidence-based protocols, as I stated, are missing, and the optimal management, again, should be through a multidisciplinary team approach. Surgical resection, of course, remains the only chance for cure. Similarly, here in the paper of Adam, it shows again that the resection, as I show you, is what is going to give you better survival. One more time, turning the unresectable into resectable on these patients, it does give you a better survival rate once you do the chemotherapy. I'm going to just illustrate 2 of cases. This is a 29-year-old with multiple metastases throughout the liver, except in segment 2 and 3, that came to us with the colon tumor still in place. Then we proceeded with doing neoadjuvant therapy for 3 months, 3 treatments of FOLFIRINOX and Avastin, and then followed by 2 treatments of FOLFIRINOX. Restaging, imaging restaging showed good tumor response or no lesions in the liver. I am not a fan of ALPS, but I do believe that occasionally it is a good procedure, like in this patient, that you had a very small 2, 3, and 1 segment. And after we did the ALPS procedure, you can see, and this is the line of the ALPS up here. It was a small dissection. You can see the growth of the liver, up to 33%, and we proceeded then to do the completion of the ALPS, and this is the follow-up. You can see the massive, this is the 6-month follow-up, the massive enlargement of segments 2, 3, and 1 on this 29-year-old. This was the initial size prior to resection. This is another 54-year-old patient that presented with the tumor still in place and a very large metastasis, 2 very large metastases on the right lobe and segment 4. We proceeded doing an ALPS procedure, and you can see here the split of the ALPS procedure. and an ablation of a lesion on segment 2 and 3. This was done at the same time of the ALPS, this ablation. And subsequently, with chemotherapy, those lesions decrease in size. And you can see here enlargement of the tumor, the ALPS, and then the resection. And this is the very large lobe with a central pancreatectomy. This is the video. Because of time constraints, I'll pass out. The take-home, I'm going to skip. The take-home message: tailor the management to each patient. Multidisciplinary team approach is a must, and something that we don't want to hear but we need to adopt is the surgeon is no longer the one that makes the decision in isolation. Thank you very much.